Good afternoon. It's great to be here to address you. Today I will be talking about thyroid disorders. Our objectives will be to spend just a couple minutes reviewing thyroid physiology. We'll spend a good amount of time talking about the interpretation of thyroid function tests, the different types, what they tell us, and when to order them. And then we'll spend the bulk of the time actually talking about specific thyroid disorders using a case presentation format. The thyroid is part of the hypothalamic pituitary thyroid axis. The hypothalamus produces TRH, which through a portal system reaches cells in the anterior pituitary gland. Stimulated, these thyrotroph cells produce TSH, which circulates in the body and acts on the thyroid gland itself. It causes thyroid cell growth and cell division, organification of iodine, and also the production of T4 primarily, and to a lesser extent T3. Now we know that T3 is the more active form of thyroid hormone. Most of T3 generation, about 80% of it, occurs through peripheral conversion of T4, and that's regulated by conditions within the cell itself. So it might be within your liver, for example, or in your brain. Thyroid hormone feeds back upon the hypothalamus and pituitary to suppress the secretion of TRH and TSH, completing the negative feedback loop. And thyroid hormone has a wide variety of actions in its target tissues. It's important for CNS development. So that's why it's so important to detect and treat congenital hypothyroidism. It's important for normal linear growth as well as pubertal development. It regulates our basal metabolic rate, so it's an important factor that can promote or hinder weight loss attempts, for example. And it also has a role in nutrient metabolism, how we utilize the nutrients we take into our body, what gets partitioned into fat and into muscle. So T4 is converted to its active form of T3 through what's called outer ring deiodination, and that's regulated or actually carried out by the enzymes D1 and D2. Again, T3 is the more potent form of thyroid hormone, but T4 can also be inactivated and converted into what's called reverse T3 through inner ring deiodination. And every time I give a talk, I have to figure out which is the outer and the inner ring, but this is the outer and this is the inner ring. There are other metabolites as well, T2, reverse T2, for example. But what's known is that T4 is active and T3 to a greater extent is an active form of thyroid hormone. So let's compare T4 versus T3. T3 has about 10 times the potency of T4 as far as stimulating the thyroid receptor. T3 has a much shorter half-life, which is an important consideration for the small number of patients who take T3. They're both highly protein bound, but T4 is about tenfold more tightly bound to protein. TBG is the predominant binding partner for both hormones. Whereas 20% of T4 is bound to prealbumin, in the case of T3, 20% is bound to albumin. So prealbumin is also called transthyretin. So when you get a total T4 or a total T3, you're getting the free fraction, but you're also measuring the fraction of thyroid hormone bound to all of these partners. So any condition that alters your circulating protein concentrations will affect your total reading. So that's important to keep in mind. And we already said that it's really a small proportion of your T3 that's actually synthesized and released by the thyroid gland, and most of it is generated through peripheral conversion. So to summarize that section of the talk, The iodination state, so T4 versus T3, is what determines the activity of thyroid hormone. That allows different cell types to regulate in a more fine-tuned fashion what the local levels of active thyroid hormone are going to be. But it also means that some of that is out of our reach if we're just giving thyroid hormone itself. And then the other major point I think made through this introduction is that thyroid hormone is highly protein bound, and it's really the free fraction that is biologically active. So I'm not using the audience response system, so I'll just describe the cases. The first case is a 14-year-old female who has an abnormal thyroid test. Her chief complaint has been weight gain and fatigue for the past 3 months. And these are her thyroid function tests. You can see that her TSH is within the normal range between 0.5 and 5, and her T4 is elevated, with the reference range being 4 to 12 micrograms per deciliter. So what other tests would you like? And really before that is, do you think there's an abnormality with this patient? And you know, what are the clues to that? I mean, things that we look at are what the tests are themselves. So we had the TSH and the T4. What the patient's symptoms are like, and are they consistent with those abnormalities in the tests? In this case, the test you really need is the free T4, because it is, as we said before, it's what captures the free fraction of the hormone, the biologically active portion. And in her, the free T4 is actually normal. So in this patient, because the TSH is normal, this is actually a euthyroid patient in spite of the total T4 being elevated. And so she has what we call euthyroid, meaning her thyroid status is normal, hyperthyroxinemia. So thyroxine is the word for T4. So elevated T4 in the bloodstream, but overall euthyroid status. So there's several situations where we can run into euthyroid hyperthyroxinemia. TBG excess, so that is a congenital condition, thyroid binding globulin excess, and that's an X-linked condition. So remember, TBG binds 75% of both T4 and T3, so a small abnormality in TBG amounts can drastically alter your total thyroid hormone levels. Then a condition that's a mouthful, familial dysalbuminemic hyperthyroxinemia. So again, it's familial, indicating that it's inherited. Dysalbuminemic, so this refers to a form of albumin in the bloodstream that is mutated in such a way that it binds thyroid hormone with very high affinity. So instead of the 20% you see, or the whatever percent it is for T4 and T3, that may be increased twofold, and thus you've got a high level of total thyroid hormone. But most common is a teenage girl who's on a birth control pill. And estrogen raises your levels of many circulating hormones, and all of those would be affected in the case of thyroid hormone. The important thing to remember in this situation is that in an otherwise healthy person, the TSH is the single best indicator of what their thyroid hormone status is. So if you've got a low total T4 or a high total T4 and the TSH is normal, probably means their thyroid status is normal. Exceptions to that rule do exist, and we'll cover some of them. So we alluded to a couple of the thyroid function tests, free T4 and total T4, for example, and the importance of TSH, but let's look a little bit more closely at these. The thyroid stimulating hormone, which comes from the anterior pituitary, as I said, kind of the best single most useful thyroid test if you had to pick one. It's of course increased when your thyroid gland fails for whatever reason. It's removed, there's some inflammation there, the cells are destroyed, your pituitary responds by secreting more TSH. And it is low, of course, if you have autonomous production of thyroid hormone. Your thyroid gland gets stimulated perhaps by certain antibodies, or it's inflamed and sort of spilling out thyroid hormone. Your TSH drops because of that negative feedback loop. And then the TSH in this condition called Euthyroid Sick Syndrome, which we'll talk more about, tends to be normal, although it can be low in this situation. And why that's interesting, we'll get to. So the first row in our table, TSH, again, high in primary hypothyroidism. Now in secondary hypothyroidism, so what would that refer to? Well, a central problem, your pituitary or brain or hypothalamus, your TSH becomes unreliable. The main abnormality classically is that your thyroid hormone level is dropping and your pituitary doesn't respond appropriately. So usually that means a low thyroid hormone with either a low or a normal TSH level. But occasionally, so why is there an up arrow here too? Well, occasionally a little bit of TSH can be produced, but it may not stimulate the receptor fully. So we tend not to check TSH if we know somebody has a central lesion and is hypothyroid. Again, TSH is low with hyperthyroidism. And I put two arrows here to really illustrate that if somebody is truly thyrotoxic or hyperthyroid, the TSH tends not to be just a little bit below the lower limit of normal, but tends to be undetectable. So you'll often see a less than sign, less than 0.01. So the TSH is generally below the lower limit of detection in somebody who's thyrotoxic. All right, the total T4 we talked about measures both bound and unbound T4. We saw how wide the range of normal is and how sometimes that can be misleading and not a good reflection of the person's overall thyroid status. Free T4 measures unbound T4. So the free fraction, the biologically active fraction. So if after the TSH, if we had to pick between the free T4 and total T4, we'll generally pick the free T4 because it's not going to be affected as much by variations in protein binding state. All right, so we filled in row 2 and row 3 of the table, and free T4 is probably the second most useful test and goes up as you see there. And remember, T4, although it trends to be low in primary hypothyroidism, it could still be in the normal range. So if you see, for example, a high TSH and a normal T4, it doesn't necessarily rule out primary hypothyroidism. So T3, well, we talked about the T3, how it's generated, that it circulates in the body, it's measurable, it's active. So when would we check this? We know that since it's a total, it measures both bound and unbound T3, and you can get a free T3 ordered, although it takes several weeks to come back from a reference lab because it's so rarely measured and difficult to measure. Total T3 can be elevated in hyperthyroidism. So this is one of the situations where we would check a T3 level. Some people who are hyperthyroid tend to produce a lot more T3 than usual. Other people who are hyperthyroid tend to generate a lot of T4, more so than T3. Remember in the diagram where we talked about T4 potentially being converted into either T3 or reverse T3? Well, in this condition, Euthyroid Sick Syndrome, T3 is not made in much quantity, and so you'd have high reverse T3 and a low T3. So hyperthyroidism and Euthyroid Sick Syndrome are two situations where we would order a total T3. But we would not get one routinely in somebody we're evaluating for hypothyroidism because the levels can be anything, basically. They could be low if somebody's just profoundly hypothyroid, but they could be high too, because in your peripheral tissues, you may be preferentially converting what T4 you have into T3. So it turns out it's not a useful test in hypothyroidism. And reverse T3, as we just said, it's a product of the inactivation of T4, and it's increased in Euthyroid Sick Syndrome. So now we've completed the table for these basic measurements of thyroid hormone levels. T3, not useful in primary hypothyroidism, not super useful in secondary hypothyroidism either. May be useful in hyperthyroidism in people with primarily the T3 form of thyrotoxicosis, and characteristically low in Euthyroid Sick Syndrome. And then the reverse T3 tends to be elevated in Euthyroid Sick Syndrome because of that preferential generation of this inactive form when somebody's very sick. All right, but there are other tests that we get when we're evaluating thyroid function. Of course, the antibodies are very useful. Of these that are listed, it's the anti-thyroid peroxidase, or TPO antibody, and anti-thyroglobulin antibody that are markers for general autoimmune thyroid disease. So these are generally elevated if someone has Hashimoto's thyroiditis, but they're also very frequently elevated in somebody who has Graves' disease. So they're kind of generic markers of autoimmune sensitization to thyroid antigens, and you have to look more closely at the clinical picture and other tests to determine, well, is this autoimmune sort of hypothyroidism, that is Hashimoto's, or autoimmune hyperthyroidism, which is usually Graves' disease. There's also what's called the TSH receptor antibody. This is a generic marker indicating that there are antibodies that are targeting the TSH receptor of the thyroid itself. It's just a yes-no kind of thing. You know, it'll give you a quantitation, but it doesn't tell you what the nature of those antibodies are. So some of the antibodies might bind TSH receptor and stimulate it, and some of them may bind it and actually block it. So the presence of these antibodies tell you, well, there's something going on targeting the receptor. And again, you use the clinical situation to say, are these stimulatory or perhaps inhibitory antibodies? Thyroid stimulating immunoglobulin is a very specific form of antibody, and it is characteristic of Graves' disease. So in Graves' disease, there's autoimmune activation, there's production of antibodies that target the thyroid, and in Graves, these antibodies are very specific and land on the TSH receptor and act like the receptor. So they're agonists, so they do all the things that TSH would normally do. They cause the gland to hypertrophy, the cells to divide, for it to become more vascular, and then to start pumping out a lot of T4. And like I said before, some people do make a lot of T3 under stimulation from these antibodies. So this sort of antibody you'd really limit to the evaluation of a patient with hyperthyroidism. And you want to figure out, well, is this Graves' disease, potentially another cause? These first two antibodies are what we use far and away more often. And again, these are kind of generic markers. Is this person who has a goiter or some abnormal labs, do they fall under this umbrella of autoimmune thyroid disease? And the TSH receptor antibody, maybe you'll look at it in situations where you're concerned about Graves' disease, or maybe somebody with unexplained, for instance, a baby, and you're wondering, well, were there some transmitted antibodies that are blocking the baby's TSH receptors? So thyroglobulin, so not to be confused with anti-thyroglobulin antibody. Thyroglobulin itself is sort of the storage form of the early form of thyroid hormone. So if you remember in histology class, looking at thyroid follicles, all the pink stuff in the middle is thyroglobulin. And thyroglobulin, it turns out, if one is hyperthyroid, it spills out into your bloodstream along with thyroid hormone. So in general, if you're hyperthyroid because of your gland, then your thyroglobulin levels are going to be elevated. If you're hyperthyroid because you're taking too much medicine, you check thyroglobulin, it'll actually be quite low. It's also checked in the setting of thyroid cancer, and the presence of thyroid globulin antibodies in particular can interfere with your assessment of the TSH value. That's a very rare situation. Okay, and then imaging as well. Our main modality of imaging is really ultrasound, but we do perform nuclear scans in some situations, and we'll talk about a couple of those as they arise when we get to the cases. So you can directly measure thyroid binding globulin, and you can see if somebody has TBG excess, this will be high. Somebody could also have congenital deficiency of thyroid binding globulin, and that will also be evident when you test for this protein. So it's increased by estrogen. Other situations, OCPs like we talked about, liver disease, and low in illness, congenital deficiency, and also androgens. So the T3 resin uptake is a rarely used test today. It measures how much binding capacity your proteins have in your bloodstream, basically. But you might see it used occasionally or available in a lab that you use. Basically, a low number indicates a high protein binding state. That means, so the number you get back from the T3 resin uptake is a percentage. And if it's a low percentage that's taken up by this resin, that means that there are a lot of protein binding states in the patient's sample to soak up all that thyroid hormone, leaving very little to be taken up by the resin. So the T3 resin uptake is sometimes used to calculate what's called the free thyroxine index. Sometimes this is called a T7. You might still see this occasionally in the lab. There's no T7 in your body. It's just a calculated number, and it's determined by multiplying your total T4 times the T3 resin uptake, or sometimes it's a T4 resin uptake, and that gives you your free thyroxine index. And this was a lot more common before they developed the assays for the free T4. So essentially, we don't order this, but sometimes you'll, again, see this in a lab. Okay, moving on to thyroid disorders. Let's talk about an enlarged thyroid gland, or goiter, to start with, because sometimes we don't know a person's thyroid status, and just on a routine physical exam, you'll detect some thyroid enlargement. So potential causes of this kind of situation include autoimmune thyroid disease, like we talked about, and in general that includes Hashimoto's thyroiditis, as well as Graves' disease. Subacute or acute thyroiditis, and we do have one case to discuss of subacute thyroiditis, is basically an infectious enlargement of your thyroid gland. Subacute generally referring to a viral infection, and acute a bacterial infection. In this situation, not only is the gland enlarged, but it's exquisitely tender. If you have a goiter, you want to distinguish, well, is this whole gland enlarged, or is just a part of it enlarged? And if it's just a part, is it one lobe, or is there a nodule? And the finding could suggest potential neoplasm, so it's an important distinction to make. Dyshormonogenesis, which is when the thyroid gland itself does not synthesize thyroid hormone efficiently due to an enzyme defect, generally causes a diffuse enlargement of the thyroid gland. And then environmental and dietary factors and medicines can also cause thyroid enlargement, and some are listed here, and I'll show you another more extensive list in a later slide. All right, this is actually case 2, but here it says case 1, it's a 9-year-old girl with growth failure. You note that she has a diffusely enlarged thyroid gland. And her growth chart shows, what do we see here? So on the height, we see that over the past couple of years, her height has fallen off the growth chart. It's a general slowing of growth. And her weight has been maintained. Yours are percent increased a little bit. And because of the enlarged thyroid gland, we get a TSH and a T4. And it shows an elevated TSH, T4 probably within the normal range. But because that TSH is elevated, it's telling us, well, she has primary hypothyroidism. Even if we didn't have a T4 or free T4, we would know that. And so 2 more tests established the etiology of her condition, and those are the thyroid antibodies. So the antithyroid globulin is elevated, and then the antithyroid peroxidase is also elevated. So she's got the goiter, she's hypothyroid, she has the labs and elevated antibodies that she does. She has Hashimoto's, also called chronic lymphocytic thyroiditis. And it's by far the most common cause of hypothyroidism. It's what we see most commonly in kids. It's the kind that affects so many adults who just call it hypothyroidism. In kids especially, but also in older ladies, there's a predominance of female compared to males who are affected. It tends, if you catch it at the right phase, you'll be able to detect a diffuse goiter. So there won't be a dominant nodule. Sometimes it'll feel kind of bumpy, slightly bumpy, but it should be diffuse. Sometimes it has a rubbery quality. Long-standing, the thyroid gland will eventually atrophy, and so you might not feel it. And sometimes a kid comes in with severe hypothyroidism, and already their goiter has atrophied. So the features in kids, growth failure is pretty common. And then there are other ones, you can see a lot of the symptoms, which a lot of them are pretty nonspecific and, symptoms of modern life. We, of course, depend highly on the test to really help us sort this out. Now, Hashimoto's can have a hyperthyroid phase early in the course of the disease, and we call that hashitoxicosis. So in that situation, you might have the big gland, but symptoms of someone being thyrotoxic. And you get the antibodies, and they're positive. So you might think this is Graves' disease, when in fact it's Hashimoto's thyrotoxic phase. And that generally, in this case, lasts a couple months, subsides, and then the person becomes hypothyroid. And when we talk about Graves' disease next, we'll talk about how we can distinguish these situations. So if you do have a generally enlarged gland in a hypothyroid patient, they can have a pretty big goiter, and you don't necessarily have to do an ultrasound. Of course, if there's a nodule, any kind of local symptoms, then you should do one. But in general, if we detect some thyroid enlargement in a hypothyroid patient, we don't necessarily have to get an ultrasound. So the treatment, of course, is thyroxine or T4. We let the body convert T4 into T3 as it needs to. Fortunately, in kids, that seems to be enough to alleviate their symptoms and normalize their TFTs. Younger kids tend to need more thyroid hormone relative to their body weight than older kids. And teens and adults are more in the order of 1.5 to 1.7 micrograms per kilo per day. You've seen a slide on this already, but hypothyroidism can be part of an autoimmune polyglandular syndrome, and there are 2 types, as Dr. Hayter alluded to. Type 1 is more rare and is autosomal recessive. You can see that hypothyroidism is not infrequent, but certainly not as frequent as things like candidiasis, hypoparathyroidism, and ectodermal dysplasia. Type 2 is a far more common form of autoimmune polyglandular syndrome. It has the female predominance compared to males. It's really characterized by the presence of Addison's disease or primary adrenal insufficiency, but thyroid disease is the second most common autoimmune condition. And notably, to distinguish between them, some of the features up here are basically not observed in type 2, whereas they're very characteristic in type 1. All right, so the next case is a 7-day-old infant with an abnormal thyroid test on the newborn screen. Physical exam for this baby is unremarkable, and the history is as well, except for this abnormal thyroid test. Because of the abnormal screen, confirmatory thyroid tests are sent, and we get levels like this. We get a elevated TSH and a low T4 and a low free T4. So that tells us basically, yeah, this is primary hypothyroidism. In a newborn, it is not likely to be autoimmune or Hashimoto's thyroiditis. An I-123 scan is sometimes done. Sometimes it can be an ultrasound. Sometimes, frankly, in congenital hypothyroidism, we don't do imaging because it won't, in the short term, alter the management. But in this case, it was done. And this was the result. So this is just off the internet, not an actual partner, not an actual patient. But in this situation, you can see that what lights up with higher intensity is this area at the base of the mandible, and it's not, where it's not is the thyroid's not in its usual spot in the low anterior neck. So this is a case of lingual thyroid gland or thyroid ectopia, and that is part of this big category of causes for congenital hypothyroidism. And into this pot we include dysgenetic gland, so sometimes just half the gland forms, and frequently if it's ectopic, the gland that develops is small. Ectopia, so base of the tongue or floor of the mouth, sometimes somewhere in the upper anterior neck, and these can develop later in life and look like an enlarged lymph node or some kind of abnormal mass. So sometimes these patients come to us from ENT before they are going to biopsy it or remove it. And then sometimes, for all, as much as we search, we can't find a thyroid, either with a scan or an ultrasound, and that's called athyroiosis. So this is the most common category of causes for congenital hypothyroidism. And usually it's pretty severe hypothyroidism, and they have to be on thyroid hormone lifelong. Somewhat less common is thyroid dysharmonogenesis, like we talked about. There's one condition called Pendred syndrome, which is thyroid dysharmonogenesis associated with hearing loss. And actually the hearing loss part of that is a lot more common than the hypothyroidism part of it. And then, of course, you might not make thyroid hormone because there's some issue with your pituitary or the hypothalamus. And this might be a baby with septo-optic dysplasia or holoprosencephaly, where the midline structures of the brain do not form completely, and that can include the thyroid. And they may also lack other important thyroid hormones, such as growth hormone and ACTH, regulating cortisol production. So what are the features that we look for in congenital hypothyroidism? Well, it's usually like the baby in this case, which is it's a totally healthy baby, and you'd never have a clue that the baby was affected with hypothyroidism. But classically, and this occurs more in areas and in eras where, say, there was endemic iodine deficiency, the baby might have a large tongue and hoarse cry, look puffy, have an umbilical hernia, have low tone and be a poor feeder, just be lethargic and need to be woken to feed, and have large fontanelles, especially a posterior fontanelle. Now, that's not to say that some babies, even in Cleveland today, might not have some of these features, but that kind of classic baby with all of them is truly an exception. All right, congenital hypothyroidism. Treatment, we know that early treatment is important and leads to a normal outcome. So we want to get them on treatment, ideally within 2 weeks, but certainly within 1 month of being diagnosed. And we start off with a relatively high dose of thyroxine on a microgram per kilo basis. Although ideally you give it on an empty stomach in an older person, babies are eating all the time, so we just want to make sure that they get it in the same way every time, and we can adjust the dose as we need to. And it's important to check their thyroid hormone levels frequently to make sure the family's getting it and that the baby's levels are responding and we're making progress. So we always stress how important it is for a baby's brain development, that congenital hypothyroidism used to be the main cause of mental retardation, and then we have a mechanism to make sure that babies we start on treatment, we touch base with them again to make sure they're getting the medicine, they get the labs, and they're coming back in for follow-up. All right, and this is just a research study. I'm not going to spend more than 30 seconds on it, but they found that starting a higher dose of thyroid hormone, in this case 50 micrograms a day or 62.5 followed by a lower dose, that's illustrated in this graph. And it's IQ domain here, IQ numeric score here, and the bars represent dosing schemes. So what they found was kind of the low dose had the lower resulting IQ at age 2 compared to the higher dose scheme. So really the field has gone to higher doses, faster normalization of TSH, and that appears to improve IQ as well as growth. Okay, next case, 7-year-old girl evaluated for impulsivity and poor school performance. So maybe ADHD, but I'm an endocrinologist, so it's not ADHD. But her heart rate is 120. She's lost some weight. She's anxious. She's kind of like bouncing on her chair and her legs bouncing up and down. She has an obvious big thyroid gland. She has kind of a staring appearance, and she's got sweaty palms and a little bit of a tremor. And her labs show a very elevated T4, and again, it's that suppressed, really undetectable TSH that tells you this is primary hyperthyroidism. The gland is just acting autonomously, and it's suppressing the TSH. So in this case, imaging is done. It's the iodine 123 uptake, and the patient's uptake is elevated. So indicating that this thyroid, although hyperthyroid, in that case, without any TSH, you'd expect a normal gland to have no uptake. This uptake continues to be high. So that tells you, it's a clue diagnostically. It tells you there's something circulating, acting on the thyroid that's telling it to take up iodine and to churn out thyroid hormone. And so this is Graves' disease. And that circulating factor is the antibody that acts on and stimulates the TSH receptor. And so the symptoms, of hyperthyroidism and thyroid toxicosis, it can look like ADHD and hyperactivity. I think in our clinic, it's often things like nervousness, palpitations, poor sleep, and when severe, muscle pain, muscle weakness. Sometimes some GI complaints too. So it can really just make a person feel miserable. And the physical findings, it tends to be a big goiter. It may be so big and vascular that you can hear a bruit. They tend to be either tachycardic or with just a few steps, their heart rate just skyrockets. And so that kind of hyperresponsiveness is characteristic. They often have kind of moist palms. It can, because it's thyroid hormone promotes growth, these kids can actually have a growth spurt. They can have premature eruption of their permanent teeth. It can advance their bone age too. So looking at the growth chart can be another clue. And then exophthalmos and Graves' ophthalmopathy is less common in kids but can still occur. So it's important to monitor that and have them consult with the ophthalmologist if there are any concerns. So the tests we get, tell us about the presence of hyperthyroidism and the low TSH, the antibody status. As we said before, they tend to be elevated in all autoimmune thyroid disease, but it's really either this increased uptake on the I-123 scan, or the presence of these thyroid-stimulating antibodies. You know, this can take a while to come back. This can take a while to get ordered. So sometimes you're going more based on the clinical clues to make the early diagnosis. The treatment tends to be medical for younger kids. There's concern about methimazole. I'm sorry, that's reversed. There's concern about PTU and hepatotoxicity. So methimazole is actually the first-line treatment. Beta blocker for symptomatic relief, and then radioactive iodine or surgery for other patients. If they're not tolerating medicine, and for the older teen, we'll tend to give radioactive iodine. Okay, I'm going to skip this case. This is a case of subacute thyroiditis, very rare, but it's that tender and large gland that we treat just with supportive care, basically. All right, I am going to just end by talking about secondary hypothyroidism. This is the pathway again of how thyroid hormone is produced. What we see when there's a central lesion is that TRH and TSH are lost. And because of that, you're making less T4 and less T3. So the characteristic abnormalities are a low T4 and a low free T4. But in spite of these being low, you're not making any more TSH. So that could be a brain tumor, it could be a bike crash and a head injury, it could be an infant who's had intraventricular hemorrhage or who has a VP shunt. And in these situations, not only do we want to diagnose this, but we want to make sure that they don't have any other pituitary deficiencies that could cause, say, adrenal crisis or hypoglycemia from growth hormone deficiency. I'm going to skip this too because it's in your book, but there are a lot of environmental things that can cause thyroid problems, primarily hypothyroidism. Okay. And then lastly, Euthyroid Sick Syndrome, because I alluded to it several times earlier. You might see this in a person with anorexia, eating disorder, for example, and certainly in a hospitalized setting, anyone with a bad infection or who's had major surgery. So in this situation, what happens? Well, again, normally the thyroid generates T4, T3 principally generated through peripheral conversion. When you're sick, when you're stressed, there's something that happens in your peripheral tissues. You have upregulation of that D2 iodinase, and you start making more reverse T3 rather than T3. So T3, remember, drops down low. Your T4 may eventually also become low if this continues enough. Your reverse T3 is high. So your body basically is hypothyroid. But the unique thing about Euthyroid Sick Syndrome is that you don't get a compensatory increase in the TSH. It just kind of stays flat. So we know there are probably two things happening. One is peripherally more reverse T3 being made, but then at the level of the brain is tolerating these lower levels of thyroid hormone, perhaps as a way to preserve itself and not be too catabolic during this period of stress. So characteristically, you've got the low T3. Eventually, as I said, your T4 may go low, high reverse T3, free T4 kind of in parallel with your T4 normal or low. And in spite of the low T3 levels, low T4 levels, your TSH does not increase and in fact can even kind of drift a little bit low in spite of low circulating thyroid hormone levels. So do we treat this in general? We don't, because when it's been studied, it doesn't appear to help, and in some cases can harm outcomes in ICU patients, for example. Okay, I think I'm going to stop there. The rest of the slides should all be in your syllabus, and I'll conclude. Thanks.